Metabolic dysfunction for a lot of doctors, and certainly the way I was trained, is whether or not you have type 2 diabetes. And if you're short of that, you're okay. Metabolic dysfunction, being metabolically unhealthy, starts at that early stage of insulin resistance, when your body tends to be overweight, have too much adipose, and not responding as well as it should to the insulin signals to keep that blood sugar in a steady range. And if your blood sugar is spiking to 170, 180, 200 and staying there for an hour and a half or 2 hours after your meals, that's a sign your body's not responding well to the food you're eating and that you have this component of metabolic dysfunction and insulin resistance. As insulin is chronically high, it can prevent you from accessing your fat stores and burning your fat stores for energy. So it's a good way to add fat to the body. Second is it can actually trigger a chronic inflammatory state. We can measure the relationship between hyperinsulinemia and inflammation, and they tend to really be correlated fairly closely. Not that everybody needs to be on a ketogenic diet, but the fact that it is such a powerful treatment that contemporary medicine doesn't even talk about is just a crime. I mean, it should be at least a tool in every doctor's toolkit to be used at the appropriate time.
As a cardiologist, what is the best diet for somebody looking to prevent heart disease?
Starting off with a good one. Well, if you walk into any, mainstream medicine doctor's office, they're going to tell you it's a plant-based, vegan, or vegetarian diet. And that simply is not true. It's unfortunately true if you focus on LDL as the most important and kind of only important risk factor, because that's the diet that can lower LDL a little bit. But once you factor in metabolic health, and you factor in how diet isn't like a pill that you can prescribe, but it's something that, involves emotion and enjoyment and pleasure and our past, and how we see ourselves and our lifestyle, right? There's so many things involved in a diet that isn't involved in a pill. So I would say there is not one healthy diet for heart disease, but it's the diet that you're going to enjoy and stick with that's going to improve your metabolic health. And I think that's a really important differentiation. That metabolic health is really what impacts our risk of cardiovascular disease far more than any other solitary lab test. So I can't answer the question with a simple answer, but you probably knew that when you asked the question, would be my guess. But we get into trouble when we try to answer it with one answer. So it's not carnivore, it's not keto, it's not Mediterranean, it's not vegetarian, it's not vegan, because people are going to respond differently to those. People are going to define those differently.
It's only fair to say that going low carb is part of this, because you are a low carb cardiologist. You mentioned keto and carnivore.
Sure.
Would you not say that somebody needs to at least lessen the carbs to start regaining that metabolic health?
Well, when you phrase it like that in terms of regaining metabolic health, yes. I think if somebody has poor metabolic health, then lowering carbs is a very important part of that. But there are examples of people eating high carb diets and having excellent cardiovascular health. Now, they have lifestyles that are very different than ours. Their food is all locally sourced whole foods, on average. They tend to be physically active and not sitting in traffic and sitting behind desks all day long, and they're not overeating. They're not overweight. They're not, they don't have metabolic dysfunction. So it's perfectly possible to live a metabolically healthy life with a high carb diet. It's just exceedingly rare in our current environment, in the way our lifestyles are structured and the way our food system is structured. So I wouldn't make a blanket statement that everybody needs to lower their carbs, but once you are metabolically unhealthy and have metabolic dysfunction, then lowering carbs can be a very powerful intervention to help remedy that.
Low carb is a relatively vague term. It can mean a lot of different things to different people.
Yeah.
When you use that term, how do you define it?
Yeah, it's a good question. When I say low carb, it can be really anything less than about 100 grams of carbohydrates per day. But if you want to talk about a ketogenic diet, which is a version of a low carb diet, right? All keto diets are low carb diets, but not all low carb diets are keto diets. So if you're talking about a keto diet, you're generally talking about less than 30 grams per day of carbohydrates, sometimes less than 50 or so, but that's easy to test, right? You can test if you're in ketosis or not. It's the one diet that you can actually prove kind of compliance with and effect with by testing ketones, whereas low carb is much more vague, but I tend to use about 100 grams per day. And, you can talk about quantity, but you also have to talk about quality. If you're eating 100 grams of, cookies and pastas and bread, you fill that 100 grams up pretty quickly, but your body is going to react differently to that than if you're eating 100 grams of vegetables and nuts and fruit and seeds and, more whole foods, lots of fiber. Your body's going to see those carbs very differently too.
Somebody looking to regain metabolic health, given what you just said about quality of food, we've been talking about carbs, carnivore, keto, low carb. How does somebody begin to determine where along that spectrum of low carb is right for them?
Yeah, that's a good question too. I mean, I guess how quickly you want to change things and how far gone are things already, right? If you are 5 pounds overweight and have some early signs of insulin resistance, maybe just go on 100 grams of carbs and you're eating, 300 grams of carbs, standard American diet kind of thing, then maybe just go on 100 grams of carbs of whole foods will be plenty. If you have type 2 diabetes and you have 100 pounds to lose and very low body muscle, high body fat, that's going to take more of an effort, and especially if you want to see rapid changes. And that's someone who maybe should start with a ketogenic intervention to see if that's going to have a better effect. So, it depends on where you're starting from and what your goals are. I'm a huge fan of ketogenic diets for many, many instances, but I'm definitely not one who says everybody needs to be keto. There are plenty of people who are going to see benefits from reducing your carbohydrates if you're talking about general metabolic health. Now, if you're talking about a specific intervention, especially like a brain-based intervention, whether it's for cognitive decline or whether it's for bipolar disorder or schizophrenia, that's where it seems the ketones in the brain makes a big difference. So that's when you're not just talking about carbs, you're actually talking about the production of ketones as a therapeutic intervention. So that's a different discussion. But depending on where you start with and where your goals are, for some, reducing carbs and focusing more on whole foods is enough.
All right, we're going to get to the brain, get to ketones. But before we do, let's define metabolic dysfunction. Talk about what that is, and then the process that somebody goes down as they're heading that way.
Yeah, so metabolic dysfunction for a lot of doctors, and certainly the way I was trained, is whether or not you have type 2 diabetes. And if you're short of that, you're okay. And it sounds simplistic, but that's really how a lot of us were trained and practiced. But it's far more than that. And if you wait for type 2 diabetes, you've had metabolic dysfunction for years, if not decades. And it's really this concept of insulin resistance, right? So if you're looking just at blood sugar, our body has a pretty good system to try and keep blood sugar in check and keep it in a normal range. And that relies heavily on insulin. So we can use more and more insulin to keep blood sugar stable as our bodies become insulin resistant. So if we, needed X amount of insulin when we're healthy, as we get less healthy, maybe we need 2x insulin, but we can keep that glucose in the same level. And then eventually 3x insulin, 4x insulin, and then glucose is going to start to creep up. And then eventually you can't produce enough insulin. So metabolic dysfunction, being metabolically unhealthy, starts at that early stage of insulin resistance, when your body, it tends to be overweight, have too much adipose, and not responding as well as it should to the insulin signals to keep that blood sugar in a steady range. And, sleep can affect that. Lack of exercise can affect that. Chronic inflammation can affect that. And of course, high carbohydrate, high sugar, high calorie diets can affect that, especially when you're overweight and have too much adipose tissue.
All right, you gave a nice explanation there, the fact that insulin's going to rise over time, maintain blood glucose, which alludes us to the fact that we can't rely on blood glucose over these years, that we're becoming more and more metabolically unhealthy. You talked about the fact that people will become overweight as they're heading in this direction, but what other things can people look at without testing? I want to get to testing after, but subjectively, to determine how far down they've gone towards type 2 diabetes?
Yeah, I mean, there are a number of different things you can do. I mean, your waist to height ratio is a very simple one. And you want that waist to height ratio to be under 0.5 to suggest less likely to be metabolic dysfunction, where if it's above 0.5, more likely to be metabolic dysfunction and insulin resistance. It's kind of a crude measuring tool, but it's actually fairly accurate considering how easy it is. Body composition tests is another big one. How much visceral adipose or VAT tissue do you have? What's the body fat percentage? And then lab tests like fasting insulin levels, hemoglobin A1C, and certainly a HOMA-IR, which is a calculation using a fasting glucose and a fasting insulin, or a glucose to triglyceride index, right? There are lots of different tests that you can do. And we actually have a guide on this at metabolicmind.org and on our YouTube channel that goes through sort of the diagnosis of insulin resistance, because it's not your standard blood test, right? It's not your standard fasting blood sugar, which is unfortunately one of the least helpful tests that is very popular to use to diagnose metabolic dysfunction, but is so unhelpful. Even something like a CGM is far better because it tells you how your blood sugar is responding to your meals. And if your blood sugar is spiking to, 170, 180, 200 and staying there for an hour and a half or 2 hours after your meals, that's a sign your body's not responding well to the food you're eating and that you have this component of metabolic dysfunction and insulin resistance.
You gave a number of tests there. Somebody right now who's feeling like they're a bit overweight, they're likely insulin resistant or further down this path. What one test would you recommend if they want to definitively test to see if they're metabolically unhealthy?
Yeah, what one test? Oof.
Because you gave a few there and people, I don't want them to feel overwhelmed, and it's already going to be a stretch for a lot of people when they go ask their doctor for some of these more quote unquote obscure tests.
Yeah.
What can they take to their doctor and get done to see where they're at?
I think if you're going to ask for one thing, it would be a fasting insulin, because everybody's going to get a fasting blood sugar. But the most important thing is what level of insulin is required to maintain that level of blood sugar. So if you get a fasting insulin level, which is a separate blood test that's not routinely done, unfortunately, that in and of itself is a helpful test, but then put together with your fasting blood sugar, you can calculate a HOMA-IR. And that's not a separate test. That's just a calculation that's done by the lab or by your doctor. That is a fairly sensitive marker for insulin resistance. So I think that's probably the one thing you can do. But remember, you also, standard blood tests tend to get triglycerides and tend to get glucose. So that's another one you can easily do because most people already have the data. They're just not putting it together to look at the ratio or the index. Just make sure it's a fasted test, which is important for both the blood sugar and the triglycerides. So those are ones that are easy to do without an extra blood test. And like I said, as long as you can get that fasting insulin, that's a really good place to start. And there are others that you can do, but that's a good starting point.
Okay, coming back to the story, the piece of the story, blood glucose is trying to go up, insulin's going up and keeping that at bay. What's happening in the body physiology-wise as that's happening? Destruction that people might not tell as it's happening until it goes further down towards, say, type 2 diabetes.
Yeah. As insulin is chronically high, it can prevent you from accessing your fat stores and burning your fat stores for energy. So it's a good way to add fat to the body. Insulin it's signifying a fed state. If you think about evolution, it's like, okay, we've got a lot of calories, we've got a lot of energy, we've got high insulin. So we can actually start storing some of this because there's probably going to be a time later when we don't have it and we'll want to burn it. Problem is, in modern society, you frequently don't get to that stage where there isn't the energy around, so you don't get to access your fat store. So the first is you're building fat stores, not burning fat stores. The second is it can actually trigger a chronic inflammatory state. You can measure the relationship between hyperinsulinemia and inflammation, and they tend to really be correlated fairly closely. And chronic inflammation is something that really has multiple different cascades of what it can impact, from whether you're talking about the vessel wall, whether you're talking about organ function, right? It can impact a number of different aspects of your body and theoretically can even worsen insulin resistance. So it's almost like a circular effect there. And then if the blood sugar does start to go up, then you can, or even before it starts to go up, if it's, sort of sustained at a higher than average level or higher than normal level, I guess you can say, you get glycated end products. So you get glucose is deposited on more proteins or more cells, which can then also cause those to sort of misfunction, I guess you could say, is a simple way to do it. So there's a whole cascade of things that happen. And that's why, you can read the literature and see insulin resistance, metabolic dysfunction is associated with mental illness, with cognitive decline, with cancer, with heart disease. And you can say, how can one thing be, either causative or related to so many different things? And it's because of this sort of general cascade that it can start.
Okay, you quickly touched on heart disease, damage to vasculature, and coming back to, again, you being a cardiologist, this is your bread and butter. Let's talk about more detail in this realm. Somebody that's becoming metabolically unhealthy, why this is going to increase risk for things like heart attack and stroke.
So one thing is, as insulin increases, as metabolic health worsens, it can affect like blood pressure. That's a perfect example. Your body tends to retain more fluid and sodium in that standpoint, and more adipose tissue, is associated with higher blood pressure. Those go in conjunction with each other frequently. And higher blood pressure is going to increase that stress on the arteries with every beat of the heart. If it's pumping out at 160 millimeters of mercury in the vessel as opposed to 110, that's a big difference for every single time your heart beats and every single time the blood goes through your vessels. So that's going to create an environment where there can be more damage done to the blood vessels. We also, I mentioned about the glycated end products, the glucose being on the proteins. Well, if that's on the vessel wall, that can help injure the endothelium and have the endothelium, the inner lining of the blood vessel, not function as well. So combine that with the increased stress, and all of a sudden you've got more trauma on the vessel wall. So that's certainly one example of how it can happen. Throw inflammation, chronic inflammation on top of that, and you've got yourself a good nidus for developing atherosclerosis. Now, would I pretend to know every mechanism? No. There are probably others, and as common as heart disease is, it actually is interesting to recognize that we don't really know everything about how plaque forms and all the different factors that are in play. Certainly we know a lot, but not everything.
Let's bring LDL into the picture, because as somebody goes lower carb, traditionally, if not always, LDL tends to go up, at least for a period of time. How do you look at LDL when it comes to heart disease?
Well, first I would push back about saying traditionally, if not always, it goes up, because it actually usually does not go up. The literature that looks at ketogenic interventions for type 2 diabetes and for weight loss is pretty clear that on average, LDL does not change. And I think that's really important. Now, there is a subset of people, usually who are leaner, fitter, more metabolically healthy, where LDL will go up. But that's the exception, not the rule. And the majority of people, LDL does not change. And instead, you see HDL go up, you see triglycerides go down, obviously blood sugar and insulin go down, inflammatory markers go down. So you usually see a significant improvement in labs, including lipids. And that's something that I think is really important, because there is this assumption that LDL goes up. Even if it's a high saturated fat, low carb diet, it doesn't mean it's going to affect LDL. But if LDL does go up, then, it's something that needs to be taken individually. It can mean different things for different people. But I think the key is that LDL is a relatively poor predictor of the presence of plaque and heart disease. The best predictor is the presence of plaque and heart disease, right? We can actually measure whether or not you have plaque. We don't need to use LDL as a surrogate. So for me, in my practice, when I see patients who are low carb, or if they're keto and they have high LDL, my first question is, do you have heart disease? Let's get a calcium score. Or if that's a little abnormal, maybe a CT angiogram. There are so many better tests we can do, carotid ultrasound, CIMTs, so many better tests we can do to look for the presence of vascular disease rather than looking at LDL. LDL is not the disease. The disease is plaque in your vessels. So can higher LDL increase that risk? Yes, in large population studies of the general population, there is a small increased risk. not nearly as big as type 2 diabetes or even markers of insulin resistance, but there is a small increased risk. But that does not mean you're going to get it. Even if you look at, familial hypercholesterolemia, a genetic disorder that people are born with, where their LDL receptors don't work as well, and their LDL levels are very high in the 200s or even 300s for the majority of their lives. You would think that would be a 100% death sentence, the way we talk about LDL, but it's not. It's not. There is you could say in some studies up to half of people do not even get any vascular disease. Well, how's that possible with LDLs that high if LDL is the causative factor of vascular disease? So there's definitely more to the story. And certainly when you talk about people who are metabolically healthy and in ketosis, we are now learning that is a very unique situation that probably deserves to be evaluated as such, right? Not evaluated the same as everybody else. And this is where, citizen scientist and engineer Dave Feldman and his colleagues, Dr. Matt Budoff, Dr. Nick Norowitz, and Dr. Adrian Sotomoto, who have published in the medical literature quite a bit about this topic, is really helping us sort of reframe how we see LDL, especially within the context of metabolic health and with a reason for that LDL being elevated. If you're in ketosis and need to traffic more fatty acids for fuel, that can lead to a rise in LDL. So it's saying, oh, wait a second, the mechanism is different. The baseline condition and metabolic health is different. The vascular health is different. Maybe we shouldn't see it the same. So that's sort of a long-winded answer to your short question about how I see LDL.
Well, it's interesting you brought up the fact that it's not common for LDL to go up. I thought that was pretty common knowledge in our world that is going to happen. And to arm people with that knowledge, if they go get blood tests done with their conventional doctor, that this can be a normal response to that dietary change. So this is news to me.
Yeah. I mean, if you look at a number of different published studies and even meta-analyses, most of them show on average no change in LDL. And there was one that actually showed a reduction in LDL particle number. Now, those tend to be the studies that are treating type 2 diabetes or using ketosis for weight loss. When you're talking about thinner, metabolically healthy individuals, that's where you're more likely to see the rise in LDL. So there is a difference based on who you're looking at. And again, Dr. Adrian Sotomoto published a paper looking at a number of these studies showing that the rise in LDL correlated with body mass index and really didn't correlate with saturated fat intake nearly as much, which is, again, sort of surprising because a lot of people think you eat saturated fat, your LDL will go up, period, end of story. And that is not the case. But that is what's believed by a number of people in mainstream medicine. And nothing really bothers me more than somebody saying either you shouldn't start a ketogenic diet because your LDL could go up. Well, why don't you just test it and find out if it goes up, right? It's not like this is a big secret. You can do it 4 months, 6 months, a year, whatever, and test it. Or someone would say, no, the risks outweigh the benefits. Well, what risks? Like you can test somebody for the risks, and what benefits are you even talking about? Are you talking about somebody putting their treatment-resistant bipolar disorder into remission where nothing else worked, or somebody putting their type 2 diabetes into remission where, they were on multiple medications before? Like, what benefits are you talking about? And what theoretical risks are you talking about that you can't measure and follow to see how they change? So those are two things that really bother me about how mainstream medicine sort of talks about ketogenic interventions.
Yeah, riffing off of what you just said there, it's like, for one, does LDL actually go up? And then two, does it actually matter if it does go up? And we need to ask these questions. Yeah.
I mean, there's a documentary that will be coming out called Cholesterol Code. And it's about sort of this concept, about this study that Dave Feldman and Dr. Matt Budoff and others are doing. But the documentary isn't just about the science, because that is important. What happens to individuals if their LDL goes up? Can we measure whether or not their plaque and their arteries increase? But also about the personal stories about the people who are transforming their lives with ketogenic intervention. So then how do you factor this in? And you absolutely should not take someone who has changed their life with this type of intervention and be like, oh, but your LDL could go up, so you probably shouldn't do it. To me, that's just not medicine. That's not taking care of the person in front of you.
And to add some detail to what you just said there about Dave Feldman and his buddies there, we're talking about lean mass hyperresponders. And when I was asking you about LDL going up in a general sense, that wasn't what I was talking about.
Yeah.
But you've clearly defined both now.
Yeah, good point. So you can get small rises in your LDL of, 10%, 15%. Again, on average, there's no change, but some people will see small increases. But what a lot of people think about, certainly where my brain goes when you talk about LDL rising, is this very small subset of people where it dramatically goes up, where you're maybe at 120 before and now you're at 280 for LDL, right? That's a huge jump. And that freaks a lot of people out. Understandably, it can be very nerve-wracking for a patient and for a physician. And that's what this documentary and this study is looking at, because if you want to really investigate the impact this has, it's going to be hard to investigate the impact if your LDL goes from 120 to 150. Okay, that's an increase, but what kind of impact is that going to have? But if it goes from 120 to 280, that's a dramatic change. And that's the levels that we would think would cause rapid vascular damage, rapid plaque accumulation if LDL by itself was the concern. So, it's the perfect subset to sort of study this and answer the question. So yes, that's what Dave Feldman and Dr. Matt Budoff and others are studying. But then you can look at the study published by Virta Health. This was back in 2018. I think they published a study about their 1-year results of using a ketogenic diet to treat people with type 2 diabetes. And they found on average LDL went up by 10%. But the ApoB, apolipoprotein B, which is you can think of as just a better LDL. It's a more predictive marker than LDL itself. ApoB did not change at all. And when you see metabolic health improving like that, you're going to get rid of some of the small, dense LDL. You're going to have more of the larger LDL. So that's how LDL in total can go up a little bit. But ApoB, or the number of LDL particles, isn't going to change. So LDL doesn't tell the whole story. And when you calculate their cardiovascular risk, it actually went down by 12%. So LDL went up by 10%, but cardiac risk, calculated risk, went down by 12%. And a lot of that has to do with improved metabolic health and the ApoB not changing. So yeah, we have to differentiate just small increases from the lean mass hyperresponder. But also, if you're talking about the LDL itself going up, you want to dig a little bit deeper and say, what does ApoB do, or what do your small LDL particles do, and what's your metabolic health doing? Because those are better predictors of cardiovascular risk than just LDL cholesterol.
All right, let's talk more about this subset of LDL, the different pieces, the small, dense, large, fluffy. We have oxidized LDL. For you as a practitioner, and then as somebody listening as a patient, how valuable is that deeper data?
Yeah, look, I think it's incredibly valuable. I think LDL by itself is not very helpful. Certainly you want to interpret LDL in context of your triglycerides and HDL and your metabolic health. But knowing if your LDL is mostly small, dense LDL or larger LDL is helpful. Now, it's not an absolute. And I think that's where we can sometimes get into trouble. If someone says, oh, my LDL is large, I don't need to worry about it. Well, if you've got plaque, if you've got existing heart disease and your LDL is large, I would still be concerned about it. But if you have 0 plaque, calcium score is 0, no plaque on CT angiogram, you're metabolically healthy, and you have almost no small dense LDL, that's a situation that I'm a little less concerned about. And then you mentioned oxidized LDL, same thing. Oxidized LDL, or the LDL that's really inflamed and oxidized, that's the one that's going to cause the damage. That's the one that's going to cause the plaque, especially sort of the angry, inflamed, aggressive plaques that can break off and cause heart disease or cause heart attacks. So that's the other part of the cholesterol you want to worry about. And that speaks a lot to sort of the environment in which the cholesterol lives. Is it a high oxidized, high inflammatory environment, which happens with insulin resistance and metabolic dysfunction? Or is it a low oxidized and low inflammatory environment when someone who's metabolically healthy and living a very healthy lifestyle? So those things definitely make a difference. But again, not part of the standard medical tests. And you can kind of infer from standard medical tests about that. If your triglyceride to HDL ratio is very good, you're less likely to have small dense LDL. If your high sensitivity CRP, which is a sensitive inflammatory marker, is good. You're less likely to have oxidized LDL, but nothing's 100%. It's all sort of a best guess based on those tests, but the tests are available and you can do them. And one of the things that's really cool now that didn't exist so much 10 years ago is people can get their own test. You got to pay cash for it rather than using insurance. But if your doctor's not, interested in getting these tests or doesn't understand these tests, there are websites out there, ownyourlabs.com and others, where you can get these blood tests done on your own. It just unfortunately takes money.
If somebody wants to do that and be really comprehensive and they're on their own, what are the minimal tests they want to get done to have a comprehensive view of their heart disease risk?
Yeah. And here, the terminology is tricky because Quest is different than LabCorp, is different than Boston Heart, and so forth. They all kind of have their own thing. But basically, you want some sort of advanced lipoprotein testing. And that sort of encompasses this, small particles, large particles, HDL particles, and then some marker of inflammation, whether it's the CRP or a test called a PLA2, or just an oxidized LDL test. And then tests of insulin resistance, like we mentioned before, the fasting insulin. Those are sort of basic places to start, and you can always dig deeper. And that's one of the things that Own Your Labs has done is they've put together sort of these packages depending on what you're looking at. So they're sort of like prearranged packages for the ultimate heart disease test or the base heart disease test. I forget exactly what they call them. I haven't looked at it in a while, but it's nice to have that sort of structure and that guidance.
All right, let's move deeper into plaque. Somebody that wants to get a visual on what's happening in the arteries, what's the best test? And then I know there's soft plaque, hard plaque. Let's differentiate there and talk about what's more dangerous.
Yeah. So when you're talking about hard arteries, the basic test that pretty much anybody can get is a calcium score. That is a CT scan. It takes about 10 seconds. Your entire appointment probably takes about 10 minutes. It's relatively low radiation. It's about 1 millisievert. And for reference, a mammogram is about 0.5 millisieverts. And just living on Earth at sea level by the equator for a year is 3 millisieverts. So it's 1 millisievert, and it tells you whether you have calcium in your arteries. And that is a very good start. Certainly if the answer is 0, if the score is 0, that you don't have any calcium in your arteries, studies have shown that you have a very low risk for having a heart attack over the next 10 years. It's not 0. And that's, everybody can point to one study that says, look, this person had a 0 score and had a heart attack. It happens, but it happens with normal LDL too, right? And people sort of forget to point that one out. But it's very, very good. Now, if it's elevated, that's a different story. And this is where, even though it's a good test, it's sort of a blunt test because it doesn't tell you anything about soft plaque. It doesn't tell you anything about when the plaque was developed or why it was developed. So some people can use calcium scores to follow over time to see if you're developing more plaque over time. Again, it's a bit of a blunt instrument. The better test is a coronary CT angiogram, but this is much more involved. So whereas a calcium score, if you have to pay for it yourself, is about $100. Some places maybe $75, some places $150, it varies. CT angiogram is very different. That's about $1,500 if you have to pay for it, right? So much different. Instead of 1 millisievert, now we're talking about 3, maybe 4 millisieverts. Now we're talking about IV contrast and iodine-based contrast that's injected into your vein. The whole appointment now is maybe an hour and a half. You have to regulate your heart rate, right? So you can see just by me talking about it, it's a much more involved test. But because of that, you get much better results. You actually see the arteries themselves. You see inside the arteries, not just the silhouette or the walls of the arteries. You see if there's soft plaque. You see if there's calcified plaque. You can see exactly where it is. You can see if there's any narrowings. So it's a much more advanced test. And now there's a company called Clearly. There may be others soon, but right now Clearly kind of has the corner on the market here that does an additional evaluation on those scans where it can tell you, it can actually quantify how much calcified, how much non-calcified, and how much low density plaque, which is really the highest risk plaque. It can quantify that, show you exactly where it is on your arteries. And now you know, and you can say, okay, so here I am at time 0, and this is what I'm going to do to treat this, whether it's a medication, whether it's a diet, whether it's a exercise program, a supplement, a combination of all those, whatever. And now I have an objective measure to say, am I making progress, right? Am I causing regression? Am I halting progression? Or is it still rapidly progressing despite what I'm doing? That is so important. That's the information everybody needs. Unfortunately, it's not available for everybody. But gosh, when I use this with patients in my practice, it is just, it's mind-blowing how precise, how specific, how much information we can get from that test. And I wish it was widely available to everybody.
Okay, you say everybody, but what about somebody who is metabolically healthy? I want to get an idea of prevention. I know you're really big on prevention. Somebody who's middle-aged, they're normal weight, they feel like they're metabolically healthy. We've talked about blood. We've talked about now looking at the arteries. What would you say somebody would want to do preventatively to see where they're at? And then how often would they want to monitor?
Yeah, I mean, because somebody's metabolically healthy now doesn't mean they always were metabolically healthy as well. So it depends on, how old they are and what their lifestyle was like before. That's all really important. But a calcium score is the place to start. And hopefully the calcium score will be 0. And then it's also age-based. A calcium score of 0 at age 40 has a different prognostic factor than a calcium score of 0 at age 60, right? It's much more powerful at age 60 to have that 0 than age 40 to have that 0. So how often you're going to check, depends on what you're doing and what are the risk factors you have and how old you are. So if you have a 0 at 40, maybe you check it 5 years later, right? If you have a 0 at 60, I don't know, maybe you check it 10 years later. Now, if it's not 0 and you want it, then you're going to want to follow it more closely. And again, it's hard to give general recommendations because it depends on the age and the score and what you're doing differently. Some people check them every year. Some people will check every year until sort of you see some sort of stability or very slow progression, and then space it out to every 2 or 3 years. There are lots of different options there, but I think the calcium score is the place to go. Dr. Matt Budoff, who's one of the, I guess you can call him one of the forefathers of calcium scores, has referred to it as the mammogram of the heart. You don't think twice about getting a mammogram just about every year for most average women. So he would say you shouldn't think twice about getting a calcium score every year or every other year for most average people. That hasn't quite caught on, but it's an interesting concept because it's such a better measure than an LDL blood test. Because I said it before and I'll say it again. LDL is not the disease. Heart disease is the disease.
For somebody that has testing done, they see that they have plaque buildup. What do they do at that point? They decide to take on what we're going to get into today, become more metabolically healthy. What hope do they have to reverse that plaque? Yeah. Or is it just about maintenance at that point?
Well, I like that you said they're going to become more metabolically healthy because often what happens is, the discussion goes, your calcium score is 50, 100, 200, whatever it is. Here's your statin prescription. And I like how you said it. They decide to become metabolically healthy because the discussion should go, you have, calcium in your arteries. Let's make sure we have a very, very thorough test of your metabolic health. And let's make sure we improve that significantly. Then maybe a statin or maybe treating LDL is part of the discussion, but it's not the only discussion. Metabolic health is first and foremost. But there are studies, again, in the general population that show if your calcium score is above 100, and you put half the people on a statin, half the people not on a statin, or actually, let me rephrase that. It was an observational study, but for people whose LDL was above 100 and those who went on a statin versus those who didn't, those who went on a statin had a small decreased risk of heart attacks. Now, if the calcium score was 0, there was absolutely no difference 10 years later. But if the calcium score was above 100, there was a small benefit to being on a statin. So that's where treating lipids can certainly come in to be part of the picture because there's something about having plaque that begets more plaque or something about having plaque that provides the nidus for LDL to then become a little more detrimental. But if there's no plaque, it's a different story. So I think that's important. Now, how does metabolic health factor into that? That's what hasn't been studied, because whenever you're studying the general population and the intervention is a statin prescription, not improving metabolic health, you can assume that you're dealing with a metabolically unhealthy population at baseline. So will metabolic health change that? It's certainly possible. And I think it's actually probable, but we don't have the strong data to point to that. We can look back and say, okay, if we look at triglycerides and HDL in these old studies, it seems to be a little more protective or have less of a benefit of treating with medications, or less of a risk if your triglyceride to HDL ratio is better. But that's different than saying, okay, we're going to design the study moving forward to look at that. Those studies aren't really powered to look at that, but it's certainly suggestive, So, that's where you really got to work with your physician and say, like, look, I am metabolically healthy. Here are my tests. Here's my lifestyle. And yes, I have plaque, but that could have been, deposited before. So does it mean I actually need a prescription for a medication, or does it mean we can follow this moving forward to see if there's progression, to see if there's regression? So you brought up that term regression. And this is another tricky one. Because when you talk about regression, like I don't believe regression of a calcium score is really the main goal. Because if you have soft plaque that you turn into calcified plaque, that's actually a good thing, right? Because calcified plaque is more stable and less likely to rupture and cause a heart attack than soft plaque. So that's actually a good thing. But the calcium score is going to go up, which is kind of thought of as a bad thing, right? So it gets a little more complicated. So again, this is where I really like CT angiograms. So when you talk about a CT angiogram with an objective plaque analysis, like with the Clearly scan, that's where you can really measure regression. Again, it's not a test that anybody can get, unfortunately, but that's how you measure regression. So that's the only place I would really talk about regression. When you're talking about calcium scores, I wouldn't talk about regression. I would talk about slow progression or lack of progression, or trying to make sure there are no new areas of plaque. Those are a little more nuanced interpretations. But yeah, when people, there are cases online and people say their calcium score regressed or went to zero. A lot of the times that might be technical issues. A lot of the times it may actually be true, but I think that's too high of a bar to set for the average person and may not be the right goal.
So we know metabolic health is connected to heart disease. As a cardiologist, how often would you see somebody come to see you who's been metabolically healthy, is currently metabolically healthy, but yet still has plaque building up? Mm-hmm. How definite is that connection?
So they were metabolically healthy, and they've been metabolically healthy for years and years and years, and now have plaque, or they were previously not metabolically healthy? Sorry, I want to make sure.
Basically, other risk factors have come in, say it's smoking or fried foods. I'm just making these up, but basically, can you assume when you see that plaque that somebody is metabolically unhealthy or they've been metabolically unhealthy?
Yeah, so that's tough. Yeah, I mean, it's probably the most common risk factor, but sure, you also get people who smoked, a pack or two a day in their 20s or 30s, and they'll come to you with plaque in their 40s, and smoking tobacco is a huge risk factor. Or someone who's got a really strong family history, and that's something that is unfortunate. If your dad had an MI in his 40s, you might have the deck stacked against you, and maybe you're going to develop plaque in your 50s if you're perfectly healthy, otherwise healthy, whereas you would have done it in your 40s before if you weren't so metabolically healthy, right? So you do have to weigh all those other risk factors. And that's part of the frustration. A lot of times patients come to me and they say, I want to know why I have plaque in my arteries. I'm like, well, you can't always say exactly why. Did you smoke? Do you have a family history? Did you used to have high blood pressure? Did you used to be metabolically unhealthy? There are lots of things that you have to guess at someone's past. But those tend to be the big risk factors, right? Especially blood pressure, especially metabolic dysfunction and hyperinsulinemia, and especially family history.
All right, let's work our way back now. Let's talk from somebody that is metabolically unhealthy right now. They want to make diet and lifestyle changes to work their way back. What's the beginning look like for them? And we've already talked about the low carb, the keto, the carnivore. Mm-hmm. We know diet's a big piece of this. Let's start there and talk about how somebody would work their way back.
Yeah, so it really depends on what they're eating right now. And again, this is why I wouldn't say we can't recommend just one diet. You got to recommend a diet that's going to work with someone. But any movement towards predominantly whole foods and lower carb is going to be the right move, right? So that's where I really have a problem with someone with the dietary guidelines saying eat less red meat. Well, the studies about red meat that are involved, that are combined with high calorie, high carb, high sugar, metabolically unhealthy, that's very different from somebody eating a whole foods diet with red meat and vegetables, no ultra processed foods, and otherwise improving their metabolic health. Those are two completely different scenarios. So I just use that as an example that we can't make blanket statements about good food, bad foods, good diets, bad diets. It's the diet that's going to help you improve your metabolic health. For most people, that is going to be a whole foods, lower carb type diet. Now, again, the ultimate example of that is a ketogenic diet because that's a very low carbohydrate diet, but not everybody needs to do that. So, if your morning's going to look like, and I should also mention protein. We've also been sort of trained by dietitians in the, modern medicine that we actually don't need to eat that much protein, that this 0.8 grams per kilo is perfectly adequate. And that's what you need to prevent protein deficiencies, but that doesn't mean it's optimal for metabolic health and for body composition. And that's where you do want to make sure you're getting a good amount of protein, about 1.5 grams per kilogram for the average person. So, start your day. If someone starts their day with one egg and oatmeal, it's very different than if you're going to start your day with 4 eggs with some spinach and some cheese. 1, you're going to get more protein. 2, you're going to be much fuller. You're not going to get hungry as quickly, which is another vital component about a healthy diet. 3, your carbs are going to be lower. Your insulin spike's going to be much less, and it's going to get you further down the path towards metabolic health. Then chances are you're not going to be hungry again for at least till lunch. You're not going to snack in between. Whereas if you have, a bagel and banana and a bunch of fruit, you're probably going to be hungry a couple hours later and you're going to snack and your insulin's never going to have time to come down because you're snacking and you're eating, right? So that's going to not move you towards metabolic health as quickly. Then for lunch, you have a Cobb salad. Again, it's going to keep you pretty full because it's got plenty of protein, it's got the fat in there, and is relatively low carb. And then for dinner, you have salmon or chicken or steak or ground beef with a whole bunch of above ground vegetables and some avocado. And some people may be in ketosis with that kind of eating pattern. Some people may not. But that type of eating pattern is going to improve your metabolic health, especially if you find yourself being full, you're not snacking, you naturally reduce your calories. This is one of the most noteworthy things about low carb and ketogenic diet trials is if you compare it to a low fat diet and the low carb diet, and you just let them eat as much as they want, almost without fail, the low carb diet people are going to eat significantly fewer calories because they feel fuller. They're getting their protein, they're getting their nutrients, and that goes a long way, especially if they're high quality calories that are giving you your protein and your nutrients. So that goes a long way towards improving metabolic health. So moving in that direction, I think, is the first step. Now, if you want to get more detailed and work with a doctor or a dietitian or a coach or someone who can design your macros and design exactly, what you're eating when, and you can use your app, sure, you can do that. But the general concept is move in that direction and you're going to be healthier.
If somebody wants to do this in the most efficient way possible, I would assume going keto would be the way to go, unless you want to go carnivore. But what I'm getting at here is any reason somebody would want to go low carb versus keto? Or is it just for taste buds and for social situations? Why wouldn't we go keto if somebody's metabolically unhealthy to get them back?
Yeah. There's almost no reason why someone shouldn't go into ketosis. There's some rare medical conditions where you just can't metabolize the fat or utilize the fat well, but they're very rare. But yes, otherwise it is, enjoyment, logistically being able to do it, feeling deprived, being able to not feel like you're a social outcast. And none of those things have to be true with a ketogenic diet. But in our society, a lot of people do feel that way. And it's like too much of a step for some people, which is fine. Like, absolutely. You can see benefits by going low carb. So I think that's the key, and especially if, gosh, when, you read articles about keto being the worst diet and they're just so off base and your doctor says you can't eat all that fat, keto diets are terrible for you. People have this perception of, fat is bad and keto is bad. All right. In that case, let's, start you with low carb and maybe you can inch your way towards keto. But that's, those are other reasons why to not go into ketosis, but none of them are really good, sound, physiologic, medical reasons.
All right. For somebody going low carb, obviously they're going to bring their blood glucose down overall, bring insulin down overall. The other layer with ketosis is producing ketones in the body. Mm-hmm. Talk about specifically how you think of those and how they benefit metabolic health.
Yeah. So, it's so interesting to try and tease out what is a benefit from reduced insulin, from reduced calories, from reduced body fat, and from actually having ketones. So you can think of ketones as two ways. One, you could say they're just a byproduct, right? You're burning fat for energy and ketones are a byproduct and, so be it. Or the research actually shows that ketones are an active molecule. They have actual active benefits and they're not just a byproduct and innocent bystander. There's one study showing about the NLRP3 inflammasome. So ketones can actually directly decrease inflammation. There are some studies suggesting that ketones have an actual satiety benefit to make you feel fuller and not as hungry. Ketones themselves can be used for energy. They're, an active signaling molecule that can affect the genes themselves and the histone deacetylates. And then when we talk about the brain, that's where ketones really thrive because your body can use fatty acids for energy very efficiently. The brain does not use fatty acids as efficiently for energy, but can really efficiently use ketones. So if your muscles are using the fatty acids and not requiring as much glucose, you don't want your brain still using all that glucose, but the brain can use the ketones and reduce its use on glucose. Now, it's not 100%. Even some of the early starvation studies suggest maybe 70% ketones, 30% glucose. That's still a pretty dramatic effect, especially if the brain is suffering from insulin resistance or poor energy utilization of that glucose. So allowing the brain to use ketones is so effective, and it's been shown for over a century and then for decades with clinical research that it can reduce seizures, especially refractory seizures. So your kids are taking medications and not seeing benefit, but then ketosis can reduce or even eliminate seizure frequency in a number of these individuals. And now we're seeing it with mental health as well, with bipolar disorder, schizophrenia, depression, possibly even anxiety, OCD, PTSD, that they can see dramatic improvements with ketosis, a lot likely having to do with the brain energy. And the same with cognitive dysfunction. Alzheimer's disease, even maybe Parkinson's disease. So it's really sort of cutting edge research now that we're learning so much more about the benefits of ketones in the brain. And still, improving metabolic health can improve all those things, but metabolic health without the ketones in the brain doesn't seem to be as effective as with the ketones in the brain. So that's pretty exciting about ketones as a therapeutic potential.
Somebody that's gone low carb, not quite ready for keto, but they want some of these benefits from ketones. How do you feel about C8 MCT oil, exogenous ketones?
Yeah.
Say going low carb and then adding those as an adjunct to that diet.
Yeah. So the easy answer is we just need more research, right? We just need more research to know if that's going to be as effective as a ketogenic diet. But the other thing is it's something you can just test in yourself, right? So people can do this on their own to see if they get the benefits or not. There's practically no harm to taking MCT oil, to taking exogenous ketones. There's the cost of it. And if you take too much, you might get nauseous or have some GI side effects or diarrhea or something, but you'll learn that pretty quickly and work your way up to it. But yeah, it's definitely worth doing. Like some people, I talk about the brain benefits from the perspective of like treating a brain ailment, but there are also people who just say, I think clearer, I have less brain fog. I can concentrate better. And there haven't been studies really looking at that, but there have been so many, individual reports and people's clinical practices where they see this over and over again. And people can see that from exogenous ketones as well. So I think there is room for a mix of it. Where I'm not so sure the exogenous ketones help is like just for, weight loss or for improving metabolic health. I mean, I really think you need the lifestyle and diet, sleep, exercise, et cetera, for that. But for brain-based benefits, I think that's where you could see more benefit from exogenous ketones.
The other piece of that I wonder about is how is that person's metabolism able to utilize that fuel if they haven't trained it? So they're a carb burner, sugar burner, and they're putting those in. Their body isn't used to those. Can they utilize them the same? Just a thought experiment.
Yeah, and it's fascinating, I think, from a evolutionary perspective. Like this is the one time in evolutionary history that we can have high glucose, glucose utilization and high ketones. Like when would that ever exist previously? It couldn't have. It just seems like physiologically impossible. So who knows what's going to happen? The
other tool that fits nicely into this part of the conversation is fasting. So intermittent fasting, longer fasts. Obviously, that's even more extreme than carnivore, bringing no food in and allowing the body to metabolically heal during that phase and also potentially produce ketones. So talk about how you feel about fasting.
Yeah, fasting can be a really powerful technique. But it's important to define, like, what are we talking about with fasting, right? For some people, not eating for 12 hours is considered fasting. And for some people, not eating for 5 days is considered fasting. So, time-restricted eating, not eating all day long, eating in a 8-hour window or a 6-hour window, I think can be really beneficial. Interestingly, the science is a little split, and a lot of it depends on the study structure. And this is a great example on how you can't just sort of use one study and extrapolate it to everyone. I remember there was one study looking at time-restricted eating versus not, and the people in the time-restricted eating window actually ate more calories. And they didn't see as many benefits. And okay, maybe that's not such a surprise. And they didn't really regulate the quality of food. So, I think if you're eating high carb, high calorie, high refined carb, processed foods, maybe it's not going to do a whole lot. But if you can use it as a tool in your otherwise healthy diet, and use it as a sustainable way to reduce your calories and give your body more time where nutrients aren't coming in and your insulin level can go low and stay low. There definitely can be benefits. Now, it's not for everybody. Absolutely no question. It's not for everybody. Some people do get sort of this rebound hunger, or just a psychological feeling that you need to eat more because you didn't eat for that period of time. I've got a number of people in my practice who I try time-restricted eating, and that's their response. And I just say, forget it. It's not for you. Not everybody needs to do it. What's interesting, though, is as people go low-carb or keto, a lot of people will naturally tend towards that way. If you're used to breakfast at 7, snack at 10, lunch at noon, snack at 3, dinner at 6, all of a sudden, like, oh, wait, I haven't had my snack yet, and I just missed lunch, and I kind of didn't even think about it. And it's like revolutionary for them to think that way. Well, a lot of people experience that when they're in ketosis. And I think that's just, sort of a natural, healthy response, as long as you're getting enough protein, as long as you're getting enough nutrition. And so that's something to definitely pay attention to. Now, the longer fasting, the 3 to 5 day fasting, that also has a place. I guess from my personal standpoint, I think it's miserable. Like, I don't think it's any fun whatsoever. I hate doing it. So if I'm going to do that personally, I better be pretty confident I'm going to get some benefits out of it. But this is where the whole longevity field, sure, it can help with weight loss. Sure, it can help with metabolic health. I think there are better ways to do that. The main benefit, I think, for longer fasts like that is the potential for this longevity research, for stem cell regeneration, for reducing the size of organs, a lot of the surrogate type data that suggests it may be good for longevity. Again, not doing it very often though, because you're going to lose some muscle mass. You need to make sure you're getting adequate protein before and after. It can come with some negatives, but for some people, it can really be beneficial. I just don't think it's necessary for the majority of people. Now you look at someone like, Dr. Jason Fung, and he's developed like a whole clinic, a whole practice around extended fast to help people with their type 2 diabetes, to help people lose weight. And they've got a protocol that works. So for those people who really want to do it and it works for and are committed to it, by all means, I just don't think it's necessary for everybody.
So we're starting to stack up different tools, including going lower carb, fasting. We've talked about a whole bunch of different stuff. As to not overwhelm the new person who is overweight, even type 2 diabetic, or anywhere along that continuum of insulin resistance all the way to type 2 diabetes, what would you say to them to not overwhelm them are the best tools to at least experiment with in the beginning to help them start on this pathway?
Yeah. And, like we talked about with the diet, going lower carb, going whole foods, going higher protein, and then stop snacking, right? That doesn't mean fasting or time restricted eating, but stop snacking. Like, it's so, on the one hand, sort of hilarious, and on the other hand, incredibly frustrating to think that we were teaching people for so long, you got to eat 6 meals a day, small frequent meals to keep your metabolism up. And like, there's really not much science behind that. And that's not the healthy way to eat. But so many people believe snacking is perfectly innocuous and something important to do. But eliminate snacking first and do that by helping people feel fuller with their meals, by higher protein meals, whole foods, lower carb meals. So that's a great first step. And exercise is another perfect example, right? If someone feels like they need to go to the gym and pump iron 5 days a week, and that's what they have to do for exercise, a lot of them aren't going to start. It's just a non-starter. So in the beginning, just move your body, right? Everybody's got a smartphone now that tracks your steps. Whatever steps you're doing now, get 3,000 more. And then after that, get 3,000 more after that. And just make sure you're moving your body so you're not sitting. And then maybe eventually you can start talking about a more structured exercise program that has some resistance training, that has some dedicated cardio, maybe with some interval training. But if you start there, you're going to overwhelm people and lose a lot of people. So first, just start moving your body and then graduate to the exercise program. And sleep. I mean, we often don't talk about sleep nearly enough. Make sure you are in bed 8 hours a night. May not be asleep the whole time, but if you're only in bed 6 hours a night, you're really giving yourself a barrier to start with. And people think, sleep is the one thing that people can really blow off and think is not that important. Like, I don't need sleep. I do fine. Well, you may feel fine, but you don't know what's going on inside you when you're not sleeping well. And insulin resistance, chronic inflammation have been associated with poor sleep. And poor decision making. There was one study that actually I really liked. There was one group that was sleep deprived for, I think it was, I got to revisit this. I think it was 3 days versus one group that wasn't. And they took a cognitive test and reaction test, and they both felt like they did very well. Like when you asked them how they did, it was almost equivalent. But the sleep-deprived group did terrible. They did not do well at all, but they felt they did just as well as the other group. And that, to me, that really shows how sleep deprivation and not getting adequate sleep can really sort of mess with our bodies and our brains.
I want to add a little bit to that snacking piece for people that feel like I couldn't go more than 2 hours without a snack. And you touched on this. When you start to change what you're putting in the body, that's going to become easier. If you're continuing to eat the junk food, the high carb, naturally you're going to be hungry every couple hours. That's only normal for that fuel going into the body. So it's hard probably for a lot of people to understand that until they try and increase the fat and the protein and then start to see the way their metabolism's changing.
Absolutely. Oatmeal with brown sugar and raisins, I guarantee you are hungry 2 hours later. No question. 4 eggs with cheese, avocado, and some vegetables, you're probably not hungry for 6 hours, right? Like it's a huge difference. What you eat makes a very big difference.
I want to come back to the brain. And this is an area you're passionate about, you know a lot about as the director of Metabolic Mind. For somebody that feels like right now, for whatever reason, whether it's dementia or mental health, you mentioned both of those before, they want to experiment with ketosis as a tool to help with prevention or even to help reverse that. How do they know how deeply to go into ketosis to get benefits?
Yeah.
Because there's ketosis and there's ketosis. There's
Mm-hmm.
quite a spectrum even within that. So from your experience, what level of ketosis do we need to get to before we really start to notice the difference with the brain?
Yeah. It's questions like these where I really, really love my position at Bazooki Group and Metabolic Mind, because I get to interact with so many experts on a daily basis, whether they're clinician experts or experts by experience with their own personal experience. And one of the lessons is it varies, right? Now, in general, it looks like most people are going to see the highest brain effects in the 1.5 to 3 millimole range. But that's going to be different for everybody. So actually at Metabolic Mind, we're launching Think Smart, which is going to be a community-based tool basically for people to share their experience so we can learn from the community, right? And, someone like Lauren Kennedy West, her ketones are in the 4, 5s, and 6s. And when they come down to 2, she doesn't feel good. She notices her psychiatric symptoms come back. Other people can be, at a 0.5 to 1 and feel great, and have complete resolution of their psychiatric symptoms. So I wish I knew why there was such variation, but it's clear there's variation. But I think on average, we can say probably in that 1.5 to 3 range for brain-based benefits, but don't take that as a hard and fast rule. You got to experiment. You got to do your own experiments. You got to test. You got to see how you feel. And respond appropriately. But I think once we launch this Think Smart program, we're going to learn a lot more. Just, community source it and learn from other people's experience. It's going to be really exciting.
You talked about one specific patient there that when she dropped down from, I think it was 5 or 6 to around the 2 range, her mental health symptoms would come back on.
Right.
Is there a certain period of time that you find, and obviously this can depend on the person and their situation, but that somebody needs to go on a ketogenic diet, create ketones for the brain, fix their metabolism, and then over time can maybe introduce more carbohydrates and be more flexible over time?
Yeah. Great question. And the answer is yes, for some. So other examples, and of course, these are personal examples. We're going to learn more through research, but, at Metabolic Mind, I have the pleasure of working with Hannah Warren, and she had mentioned to me how in the beginning of her ketogenic journey, she needed higher ketone levels, right? Like around 3, to keep her symptoms away. And now she's perfectly fine, at 1 or below. And, so that changed over time. There's another gentleman who in the beginning needed to be in strict ketosis and now actually is in ketosis Monday through Friday, and Saturday and Sunday, kind of gets a lot more lax with the family and comes out of ketosis and does just fine and picks it up again on Monday. Now, if he stretches it to, out of ketosis to Monday and Tuesday, he'll start to see symptoms come back. But he's worked it out for him where he knows where his level is. But it wasn't like that in the beginning. So there are examples of that. Is that going to be the same for everybody? No, it's not. There's going to be a lot of personal variety. And look, the research is exploding in this area. And in the next couple of years, we're going to have so much more data because I think there are like 15 clinical trials going on right now or about to start enrolling. And so there's going to be a lot more to answer these questions. In the meantime, that's why we want to create a resource like Think Smart, so we can sort of crowdsource the learning and people can learn from each other as we're getting more of this research evidence come in.
For somebody that's deep in ketosis, they're finding benefit there, say for mental health, but it's been like a year or 2, and they're starting to Google online and hear people say, ketosis long-term, you can't do that. You start to run into health problems. What's the research showing with that?
Yeah, so we did a video on our Metabolic Mind YouTube channel about this specifically. Well, can I do keto long-term? And basically anybody who says there's evidence that long-term ketosis is dangerous is simply wrong. There isn't evidence that long-term ketosis is dangerous. Now, there isn't evidence that long-term ketosis is safe. because it hasn't been looked at, right? It just simply hasn't been looked at. But anything to suggest it's dangerous is just simply wrong. And a lot of the problem is when you look at the studies, they'll look at, this study shows low carb. The people who are low carb have a higher incidence of heart disease or dying prematurely. And they're observational studies, nutritional epidemiology, which are very low quality studies to begin with. But then they define low carb as 40% of your calories from carbohydrates. That's 40% of your calories from carbohydrates, where a keto diet is like 5% usually. So you're talking about, 20 or 30 grams per day versus 200 grams per day. Those are not even in the same ballpark. So to assume one equates to the other is just wrong. But those are the studies most often cited when saying you can't do keto long term. And the other is the heart disease concern. It's going to raise your LDL. It's going to give you heart disease. Not proven whatsoever, right? And so there's no evidence for that. And if you're using it to improve your metabolic health and, to improve your brain function and your mental health, like where's the concern there? So no, there's absolutely no evidence that long-term ketosis is dangerous. And the evidence people cite is just doesn't apply really. So, so it's something that you just need to follow for yourself. How is your health responding? How is your metabolic health responding? How is your cardiovascular health responding? We can test for these things. We don't have to guess.
For most people, when they adopt a ketogenic diet or even low carb, they're going to tend to include more animal products and more saturated fat, which you've brought up a couple times. But I want to go deeper on that because that is a fear that could be a potential roadblock for a lot of people who over the years have heard saturated fat is going to cause, heart disease, heart attacks, strokes. Let's talk more about saturated fat specifically and put people's minds at ease. And again, as a cardiologist, you're the perfect person to do this.
Mm-hmm. Yeah, well, and the first thing I always have to start with is a keto diet is not one diet. It's any diet that lowers carbs enough to get you into the state of ketosis. You can do that with a vegan diet. You can do that with a vegetarian diet. You can do that with a Mediterranean diet, all low saturated fat. So by no means does it have to be a high saturated fat diet. Now, the way it's frequently thought of, and probably the majority of the people who practice a ketogenic diet do eat higher than recommended amounts of saturated fat. But again, you got to go back to what is the quality of the evidence that either red meat specifically or saturated fat is harmful for cardiovascular health. And if you're talking about general population studies, those studies that are observational studies to just follow people over, 10 or 20 years, and they do a food frequency questionnaire 1, 2, 3 times at most during that 20-year period, right away you're dealing with very low quality evidence. And then how do they define saturated fat? Well, there's saturated fat in cookies and cakes, and baked goods. There's a burger, which includes the burger patty, but also the bun and also the ketchup, and usually associated with French fries and a sugary drink, right? So lasagna is a saturated fat, with so high sugar in the sauce and the noodle. So it is the messiest data you could possibly have. So to try and take that quality of data and then say the outcomes are meaningful, especially when there's also this concept of healthy user bias, which means when you look at the people who eat more saturated fat compared to less, the people who eat more exercise less, they tend to be less educated, they tend to smoke more, drink more alcohol, more likely to be overweight, eat more calories total. And it's not that the saturated fat caused them to be less educated or to not exercise. It's just how they are, right? So you factor in that bias that exists before the study even starts. So for any of that to have a meaningful outcome, there has to be a very significant difference in the cardiovascular outcome, in the who lives or dies early type of results. So people say, well, what about smoking? All those things are true about smoking. Yeah. And, the hazard ratio and odds ratio, meaning sort of the effect size seen in the studies for smoking, was like 15 or 20. Okay. And when you talk about red meat and saturated fat, it's 1.2, 1.3. Compare that to smoking 15 or 20. So when you talk about all those problems with this study, the studies in this very thin margins, it's essentially meaningless. So now we're talking about someone who's eating whole foods, low carb, they're metabolically healthy, they're eating saturated fat or red meat. Do we have any evidence that that's harmful whatsoever? The answer is no. We just don't have evidence that that's harmful in that type of situation. Now, the one caveat is if you look at saturated fat and you say, okay, LDL goes up significantly with saturated fat. That is one area where there is a higher risk of cardiovascular disease, still not near the 15 or 20 from smoking. But again, now we have to say, okay, in a metabolically healthy individual, does that make a difference? But again, you can measure for that. And in the majority of the people who start a ketogenic diet, high saturated fat or not, LDL does not go up in the majority of those people. So we should not assume that it's harmful. So as you peel away the onion, you start to see that there's not much there. Now, I don't know, would that take me 5 minutes to explain as opposed to saying saturated fat's dangerous, boom, move on, right? It's a lot harder to kind of go through the nuance and talk about the details and the specifics. But when I'm seeing a patient in front of me, I want to know what's the effect for that person. What's going to happen to that person? Not what a 100,000 person population study shows that does not apply to this individual sitting in front of me at all. I want to know about the individual in front of me or me as an individual, right? Like I've certainly done a lot of my homework on this. I have no problem eating saturated fat. My metabolic health is excellent. My calcium score is 0, right? My blood pressure is perfect. Like these are the things I'm following, not some perceived threat from saturated fat when there are things I can measure. And I know the data about saturated fat has nothing to do with me as an individual.
All right, well, let's add another layer onto saturated fat. Carnivore diet. Somebody totally eliminating plants. Likely saturated fat is going to be at another level. How do you feel about that diet in general?
Yeah, that's a good question. And this is somewhere where I've definitely evolved. I mean, I wrote a book, I don't know, 10 years ago, 5 years ago, somewhere around there. I don't even remember. And when I wrote the book, I was sort of like, you shouldn't be carnivore. There's, you got to have half your plate full of vegetables and still low carb, right? But I was not a fan of the carnivore diet. But when I stopped to think about it, I'm like, well, why? Why am I concerned about the carnivore diet? And it's just because I've been taught forever, you need your fruits and vegetables, right? I got over the point that you need your healthy whole grains. So can I get over the point that you need your fruits and vegetables? And it's the same concept. Like there's not one diet for everybody. Some people react very poorly to vegetables. That is true. I definitely stopped short of saying, everybody needs to avoid vegetables. Sure, you can talk about phytates and anti-nutrients, and those are all true to a degree, but that doesn't mean they're going to affect everybody. In large population studies showing healthy populations eating plenty of fruits and vegetables shows, it can't be that bad if they're, subsisting on those foods and still living healthily. But that's very different than saying everybody needs them and a diet without them is unhealthy. That is a different statement. And to see people change their lives on carnivore diets, to get rid of whether it's abdominal bloating and just GI symptoms or whether it's an actual inflammatory bowel condition or mental health. There are some people who went keto and saw some benefit but didn't really thrive until they went carnivore. Like all you have to see is a few examples of this and be like, wow, there's something there. Is it the elimination diet? Is it the more meat and the nutrients and the protein? Certainly we don't know because it hasn't been studied all that well. But there's clearly an area where a carnivore diet can be very beneficial for people and very healthy. I mean, again, you don't have to assume if it's going to be healthy or not. You can follow people's blood sugar and their insulin and their triglycerides and their calcium scores and their mental health and their, body composition. And there are so many objective things you can follow to say, is this healthy for me or not? You don't have to guess.
Well, one area we got to dive into while we're talking about carnivore is the microbiome. Obviously, this diet, no fiber. One of the big things in conventional dietitian realm, medical doctors, is to eat the rainbow, get a lot of fiber. It's good for the microbiome, good for the gut. How do you think about that?
Yeah. I think when it comes to microbiome, our recommendations are far ahead of what we truly know from a science standpoint. I had a good interview with Dr. Jack Gilbert, who's a researcher here in San Diego, who's a microbiome expert. We've got it on our podcast. And, he gets so excited about the microbiome because he and this is his life and he studies it. But even he sort of admits, we're not quite at the point where we know everything about it, right? Like it's still in its early stages of research. And how do you explain someone who's carnivore, who put their type 2 diabetes into remission or completely resolved their bipolar disorder, or feels the best they've ever felt by eating a diet that quote unquote is supposed to destroy their microbiome, right? So there's a huge disconnect. So the microbiome is one piece of the puzzle. And I'd even say it's a really small piece of the puzzle because is it the chicken or the egg? Is it the leading factor or the responding factor, right? Are we healthier because we have a healthy microbiome, or is our microbiome healthier because we're healthier, right? I don't know that the research is really strong enough to be able to figure that out. Now, microbiome transplants are super interesting. Fecal transplants are super interesting. You can do those now when it comes to something called a C. diff infection, which is totally different. But there's also like in mice and some suggestions that for weight loss, a fecal transplant and changing the microbiome can help with weight loss. But then also you have to go back to, okay, well, what kind of lifestyle is the person doing? Is it high carb? Is it exercise, et cetera, et cetera? Once you take all those other factors into consideration, I think the microbiome is going to have much less of an impact than we think. I was under the impression that we all needed to eat our fiber and we needed to eat the rainbow and have a healthy microbiome, and microbiome diversity is key. But then how do you explain these people eating a carnivore diet and thriving and looking very healthy from all objective parameters? You can't, other than to say, well, maybe in some situations it's not as important as we think it is.
Given your answer there, I think I know where you're going to go. But how do you feel about fermented foods, probiotics?
Yeah, look, I think it can be helpful. If you like them and you think they're having an impact on your health, then absolutely. Like I'm in favor of them. Do I think you need to have them? No, absolutely not. There's no need for them. A lot of and to talk about fiber, the majority of the data on fiber comes from high carb diets. And there's no surprise that if you're eating a high carb diet, the diet with more fiber is going to be better than the diet with less fiber, because whole foods, natural foods have the fiber, and processed, ultra processed and more of the junk foods don't have the fiber. So you could also say it's just sort of a surrogate for how healthy the diet is, whether in a high carb diet, whether there's high fiber or not. But once you get rid of the carbs, then how important is the fiber? And you can say the same thing for the fermented foods, right? Once you get rid of the carbs, how important is the fermented foods? Like that's a unique situation that we're learning so much more about. But if you're talking about a high carb diet, absolutely, you want more fiber, you want more fermented foods, you want microbiome probably plays a role there in a high carb diet, because that's what's been studied and looked at.
So supplements we brought up, probiotics, C8 MCTO, we could consider that a supplement, exogenous ketones. In the realm of metabolic health and beyond, what supplements do you like to recommend for people?
I think most people won't need supplements. The majority of people won't need supplements. If you're eating a whole foods diet from animals and plants, and most people won't need supplements at all. Now, you can say magnesium. Our food is, studies have shown that our food is kind of deficient in magnesium. Our soil is deficient in magnesium. So supplementing with magnesium is probably a good idea for a lot of people. If someone's eating fish, they probably don't need omega-3s. Some people hate fish, in which case I think it's good to supplement with omega-3s. Vitamin D is hard to get exclusively from food. So if someone's not getting a lot of sunlight, vitamin D supplements can be good, although I think sunlight's probably the better way to get it. What else? Anything else is, I think, would be directed based on someone's lifestyle. If they're not eating certain foods or deficient on things on their blood tests or whatever. But other general supplements, I'm not sure that are necessary.
What about creatine? I'm hearing a lot more about creatine for the brain lately, and obviously that's one of your interests.
Yeah.
Have you looked at that research?
I haven't looked at creatine very much, although my teenage son is certainly asking a lot about it to bulk up and see if it's a good thing for him. But I need to learn more about creatine in the brain for sure. That's something I haven't looked a lot into. I generally think for the average person, from a muscle standpoint, if you're getting adequate protein and doing resistance training, creatine's not necessary for muscle development. Now, if you want to be a bodybuilder or something, maybe that's different. So I wonder if the same thing applies to the brain. I don't know, but I think you start with high quality protein, making sure you're getting enough of it, make sure you're exercising and doing resistance training, and that's going to take care of the majority of what you need for metabolic health.
As we talk about different nutrients and supplementing, this brings in the discussion of different qualities of food. And different qualities of food are going to have different nutrient profiles.
Mm-hmm.
How do you look at that for yourself and for patients? Things like grass-fed, grass-finished, organic.
Yeah.
There's all different certifications now and different qualities of the health foods. So how do you look at that?
Yeah. One, it can be really confusing. So I certainly empathize with patients who get confused by all this, but there's certainly different levers or layers, I should say. And I don't want, the thought that everything has to be grass-fed beef, wild salmon, organic regenerative vegetables. If that's the barrier to entry, we're going to lose a ton of people. If you want to eat your McDonald's patties instead of your high carb, high processed food, you're going to probably do better than you were on a metabolically dysfunctional, high carb, ultra calorie, ultra processed foods, right? So I think we need to lower the barrier of entry for people to eat lower carb, more whole foods. Now, in a perfect situation where we can afford it and have access to it, yeah, I want to get my beef from a grass-fed regenerative ranch. I want to eat organic vegetables and berries. If I can access it and afford it, sure. But by no means is that necessary. I mean, because when we talk about such a poor quality diet, the standard American diet that we're starting with, any improvement from that is going to improve our metabolic health. How much further you want to go, that's going to be different for everybody. But access is the big problem there. That's how I see it. So I never have that discussion in the beginning with my patients. I might eventually get to that discussion, but almost never in the beginning. You got to set the bar lower to work on someone's metabolic health. And, so-called dirty keto or fast food keto or, even fast food low carb is generally an improvement from what a lot of people are doing in the standard American diet.
Talk about your story getting into low carb metabolic health. Because the way I understand it, you were conventionally trained as a cardiologist. And I believe at the beginning of your career, you were conventional. Mm-hmm. What brought you into this new realm?
Yeah, it was luck, having the right friends. So, I was conventionally trained. In fact, I was trained in a Dean Ornish style cardiology program. We had this great preventive cardiology program where people, would exercise together and get community support and stress reduction. And we could really be hands-on, and cooking classes for a vegan, very low-fat diet. That's how I was trained. And then, of course, in the hospital and the cath lab and all the other aspects of cardiology. But then I got out into regular practice, and it didn't take long for me to get pretty disillusioned and pretty frustrated with the lack of effect I was seeing on my patients. Like, so many people just couldn't stick to lifestyle recommendations, didn't want to stick to the lifestyle recommendations, weren't getting better. And I was a pill popper. I was just saying, all right, here's your medicine. You can't do it. Here's your medicine. And it took me longer than I would have liked, but shorter than most, I guess, to say something's wrong here. Something's broke in this system. If every patient can't do it, maybe the problem's me. Maybe the problem's what I'm suggesting and not the patient. And we would see just the revolving door of people coming into the cath lab, getting their stents and getting hospitalized. And it's like, clearly something's broken. So I started a wellness center with a friend of mine who was an amazing health coach and personal trainer. And I was just very lucky that he knew about ketosis and ketogenic diets. And so for some of our more challenging patients initially, he suggested to me, why don't we try this person on a keto diet to help them lose weight and, reverse their type 2 or improve their type 2 diabetes. And first I thought I was crazy. I'm like, no, I can't do that. I'm a cardiologist. But luckily he said, have you looked into it? Have you read any studies about it? And I had to think about it. I'm like, no, I guess I haven't. So he challenged me to do that. And once I did, I was shocked. I'm like, oh my God, people have actually studied this and shown that you can treat type 2 diabetes with a ketogenic diet, and that their blood work improves so much, and that you can improve their metabolic health. And so once I started to go down that rabbit hole, I'm like, yeah, let's try it on the patients, and I'm going to start eating this way. And then that changed everything. I mean, once you see it, you can't unsee it. And again, not that everybody needs to be on a ketogenic diet, but the fact that it is such a powerful treatment that contemporary medicine doesn't even talk about is just a crime. I mean, it should be at least a tool in every doctor's toolkit to be used at the appropriate time. But that's where I almost felt, I felt like cheated, or I felt like lied to. And that's why I really sort of made it my life's purpose to say more people need to know about ketosis as a medical intervention. Absolutely. I need to shout this from the rooftops so that everybody learns it. And fortunately, the community is growing. More physicians are doing it. More physicians are shouting it from the rooftops, and patients are starting to understand it. And then we're learning so much more about specific interventions, like with brain-based disorders, like with mental illness, where it can be so effective. And it's just growing and growing from here.
You talked about this pivot in your diet along the journey when you started to learn about this. What does your diet look like these days? Given what you know about keto, are you typically in ketosis?
I would say I typically am. In the beginning, I would test and make sure and try and stay in ketosis. For me personally, I don't pay attention to that anymore. I don't have type 2 diabetes. Luckily, I don't have a psychiatric diagnosis. I don't have something I need to treat. So for me, it's just the right way to eat. I'll either not eat breakfast, or I'll have, 3 or 4 eggs with cheese and avocado and leftover vegetables. Lunch, I sort of gave this example earlier, and I was sort of talking about me. Lunch, I almost frequently have a Cobb salad or just leftovers from dinner, again, which are going to be a number of different vegetables and some sort of protein. And then dinner, I'll have, steak, ground beef, salmon, chicken thighs, again, cooked with cauliflower and broccoli and zucchini and, Brussels sprouts and avocado. And that's what I eat. It's kind of boring, and I don't care because I love it. I think it's delicious. It keeps me full and keeps me happy and keeps me healthy. So I don't really need to eat anything different. But that's very different for someone who needs to use ketosis to treat a medical condition and improve their health and, monitor their ketones and so forth.
Have you ever played around with the carnivore diet?
I started to, and I actually really missed vegetables. I gotta be honest. I love roasted cauliflower and roasted broccoli and roasted Brussels sprouts and zucchini. And I really love it. To me, that adds to my meal. And to sit down and have a big old steak with nothing else just felt like I was missing something. So I played around with it for a little bit, but not for very long. So maybe I'll go back to it and try it again for a longer period of time and see how I feel.
For somebody that this is all new to, they're going to embrace, say, a keto diet for, say, a mental health challenge. How important do you feel testing is? Because there's strips you can pee on, blood tests, one's certain testing kits I know you can breathe into. So how important is testing? And then talk about the different methods.
Yeah. So again, it depends on what you're doing, right? If you just want to become metabolically healthy and lose weight, maybe you don't even need to test, or maybe a urine strip is good enough to say, am I in ketosis? Am I in light ketosis, moderate ketosis, etc. But if you're using it to treat a brain-based disorder, that's where I think finger prick blood tests, like a Keto Mojo type device, are crucial. Because you really want to know that specific amount. And if you're, one thing I like to say for ketogenic therapy, rather than just eating a keto diet, you actually want to know what your target ketone level is. You want to define a target level and try and get there. And it may change over time. It is going to be different for each individual, but that you can only really get by the finger stick test. The breath tests are getting better, I guess. They don't tend to be quite as accurate, but they are improving. And for that type of specificity, the urine tests I don't think are helpful at all. What's really cool is there are continuous ketone monitors that exist, just like a CGM. They're not widely available in the US. In Asia and Europe, you can get them. I'm not sure even how widely available they are there. But I've been fortunate enough to be able to play with them a little bit, and they're really cool. And that, I think, is going to kind of take things to the next level for saying what level of ketosis should someone be in. We're going to learn so much more. If you're checking your ketones once in the morning, we know it's going to be very different, before dinner or before bed. Your ketones are going to change during the day. But I do think it's important to check on a regular basis and try and figure out, when are you at your highest, when are you at your lowest, and maybe check at those times during the day to get a gauge of where you're at, and then correlate that with your symptoms or your disease improvement, and then set your target.
One of the things I want to highlight here as we wrap up is good news within all of this is that metabolic health is at the top of the pyramid. And we've talked about a lot of different conditions under it, whether it be mental health, dementia. We could put cancer under there. Basically all chronic disease. So when you work on what we're working on today, it has a trickle-down effect in so many different areas of your life. So it's not like you need to be on this keto diet for this one condition, but then take this other supplement and switch into this diet. It sounds like a lot, but if this is new to you, this is a lifestyle and diet that, when you have it locked in, is going to reap so many different benefits in so many different areas of your health.
Yeah, I think you're absolutely right. And that's what can create a number of skeptics, right? Because people can be like, no way, this is snake oil. How can something improve your diabetes, improve your bipolar disorder, reduce your risk of cancer, and improve your heart disease? You can't take a pill that's going to do all that. So how can something do that? And it's because of this constellation of effects that can happen with metabolic dysfunction. And it's not just one thing. It can impact so many different aspects of your health. So treating that and reversing that can therefore benefit all these different aspects of your health. So the uninitiated and the skeptic is going to use that as a detractor, but really it just shows the importance of metabolic health and the importance of, lifestyle and how poisonous our standard lifestyle has become.
Bret, I think this is a great place to wrap up. Really appreciate you. Thank you for coming on the show. We're going to link up your YouTube, your website, your social media. Thank you.
Great. My pleasure. Thank you for having me on. It was a great discussion.
Now that you're done, you're going to want to stick around here and catch this other incredible episode. You don't want to miss it. I'll see you over there.
Life is just all about harvesting energy from the environment and using it to create order. And if you don't have enough energy in the system to maintain the order, you get disease. Things start to break down. And so the first place that the body seems to sacrifice is the lining of the arteries.